has done some volunteering and speaking engagements, and we received wonderful feedback on him and asked him to come back with us. So Dr. Pardo is currently a physician with the University Health Systems. He is a graduate from, and I don't speak Spanish, so I'm going to say this in English, the Catholic University in Guayaquil. Did I get that right? He then received his fellowship from the University of Texas at the Health Science Center in 2002, and he currently is a board-certified geriatrician right here. So please help me welcome Dr. Andres Pardo.
Hello everybody, good morning, thank you for being here. So what I'm going to talk about today is about diabetes in the older age and some key points about how to manage diabetes in our general population. If you have questions, just let me know anytime during the talk. It's going to be a quick presentation so you can ask questions. So I'm going to try to talk a little bit about the specific complications, how we manage diabetes with the geriatric syndromes, and diabetes on the frail patient, the very sick one, treatment basics, and some take-home points that we can do. So we have like more than 25% of U.S. population age 65 and above has diabetes mellitus. Older adults have like diabetes that is very heterogeneous, so basically it doesn't present like it's a younger adult. It can be like some periods of elevated blood sugar or hypoglycemia. It's not very often as is younger adults. In younger adults we do fasting sugars, we check A1Cs. So in seniors it's different. So the treatment also for diabetes in senior population is different because we have to take in consideration many factors that affect our seniors, like sometimes mobility, arthritis, cognitive decline. We also try not to avoid the treatment because we don't want to get all the complications that diabetes can bring to the patients. We have like seniors also have a higher risk of bad outcomes because of the same things about the physiology of aging. Sometimes they drink less water, they feel full easily, they have problems with gait or walking. So we try to balance the treatment of diabetes in our seniors depending on what they can do, what we see with them. The evidence suggests that modest treatment goals, diet versus control, versus diet control are associated with best outcomes. So basically we just try to focus on the patient, we don't try to focus on the numbers. The CDC estimates that diabetes diagnosed and undiagnosed affects 3% of people over 60%. The Framingham the data like is a long study that was done a long time ago. They're still getting information about that study. It says 40% of those patients who are over 65 have diabetes or impaired fasting glucose. And diabetes in the older patients, they are linked to higher mortality and they reduce the functionality status, and there's increased risk of put the patients on institutionalized patients, put them on nursing home, go to the hospital. It's more common when they have complications, we put them in there because of all the complications. And then when they go to the hospital because of some complication for diabetes, they end up going in the nursing home, and sometimes they stay in there. Why it's heterogeneous? Because we have like the average life expectancy right now is like 72, 79 years. We have like seniors sometimes that have 65 patients can live to 82%. So we try to focus on what is the life expectancy, what we can do to help them to live longer, to live better, and to have a good quality of life. Sometimes the difference between younger diabetes and diabetes in older ages is like the senior patients are more frail, and there are a lot of comorbidities. When we hit like 65, 70 years old, Sometimes we have heart failure, we have hypertension, we have osteoporosis, so we have to balance the treatment accordingly. They have older adults have a substantial risk for both acute and chronic microvascular and macrovascular complications. Most common complications that we see in seniors is like hyperglycemia, elevated blood sugar, hypoglycemia. They have kidney problems, visual loss. Risk of infection is more often and it's increased. And we have cardiovascular disease. And then also there are linked an increased risk of geriatric syndrome. The geriatric syndrome is frailty, walk, gait, dementia, cognitive decline. Those are our geriatric syndromes that we have to check on them as well to link it to diabetes and make sure that everything is managed in the correct way. Often we see hyperglycemia, and that's when we try to see a senior patient and treat them, they tend to eat less sometimes, but then we try to let them eat what is more pleasure for them, so they may be more sweet. But sometimes they tend to go for hyperglycemia and they get dehydrated. We try to make sure they drink a lot of fluids as well. The hyperglycemia is increased risk on elderly because of what I say. They drink less water. They sometimes they eat what is around. It could be sweets. It could be sandwiches. So we have to be careful what they eat as well. They have, like I said, increased their oral intake. Sometimes with how we manage medications, we have to make sure they are able to see what medications they are taking. It could be insulin, or it could be pills. We have to make sure that they are taking the correct pills, or they are taking the right amount of insulin. Maybe they are not taking the right amount, and then the sugar goes up. Sometimes with the hyperglycemia, the sugar goes up. They get a lot of periods of confusion that it could lead to delirium, and then they end up in the hospital. So those are the risks that we try to prevent, and we try to make sure that doesn't happen. Increased urinary incontinence, increased risk of falls as well. The other complication that is where we have to make sure it doesn't happen or is less frequent is the hypoglycemia. Hypoglycemia, the risk factors as well as the older age. With seniors, sometimes it's more common to have renal failure. Sometimes we have patients with a creatinine of 1, younger age, like 50s, 55, and then we consider normal, but when they hit 70, sometimes that can be abnormal. So all the medications that we give them, we have to make sure it's the correct amount according with how the kidney is working. Medication-wise, one of the medications that we are very careful to give to our seniors is the sulfonylureas. It could be glipizide or glyburide, because these medications are for a long time and they are filtrated through the kidney, so it doesn't get out of our body very often. So sometimes when we see patients that the sugar drops, we tend to review the medication and make sure they are out of this one. Some other risks for hypoglycemia, malnutrition, alcohol use, heart failure, post-hospitalization. Sometimes patients after being at the hospital, they tend to eat less, they are less mobile, and then they tend to be confused with medications that they get from the hospital, so there's more risk for hypoglycemia after being at the hospital. What happens if the sugar goes down? So what we're cautious or worried about is that they fall and they get a fracture, and then decrease mobility after that. So and then they get confused, dizzy, they go to the hospital as well. So that's why we're worried about hypoglycemia and how we manage diabetes in our seniors. Something that happens very often, it's not a criteria diagnosis for diabetes, but it happens very often on seniors. They have postprandial hyperglycemia. So that's another way for us to diagnose diabetes in senior years. Sometimes diabetes is usually present in the younger years. 55, like I say, we have the A1C, the fasting glucose. But sometimes we see our patients are more thirsty, and then sometimes they check their sugars and it goes above 130 often, it could be that they are eating too much on lunch, or the sugar goes up after they eat. So this is what we're careful when we see patients with diabetes. The kidney function. Like I said before, we have to make sure the creatinine, the GFR is the correct, is good, and then all the medications are appropriate for them. When we manage diabetes, we have to make sure like they don't have glaucoma, cataract, that when we give medications, they are able to see what they're taking. They're able to get the right amount of the insulin if they need to. The food care is very important because most of the complications for diabetes give you neuropathy, and they get ulcers. And sometimes when they get neuropathy, they don't have any sensations when they walk. So when they're at home, they bump into rocks, tables, and they get an ulcer. They don't feel it, and they keep going. They don't notice that, and then that develops an infection, a sepsis, and then they end up in the hospital. So those are the complications that we have to make sure when they go to the clinics and check their feet, and then when they're at home, also tell them like make sure you check your feet, make sure like everything is fine at home. They have other complications. Cardiovascular risk is increased with diabetes, but we try to focus on individualized patients. So basically, if they need medications, a lot of medications to treat the cardiovascular risk. Sometimes aspirin is in the gait. When we treat seniors, we have to make sure if there's a need for the aspirin. We try to give it to everybody, but if we see like there's a decline, a cognitive decline, it's an opportunity to use less medicines if it's needed. But we try to give it to all the patients when they have diabetes and hypertension, CHF. The hypertension in all patients and related to diabetes, we try to be more, giving a little more space on the blood pressure. It used to be very tight for diabetes. It used to be like less than 130, less than 120, and then everybody have in their minds like, I want to have my blood pressure low so I can be okay. But what happens when we are aging, our cardiovascular system kind of change. Autonomic dysfunction happens. So basically a blood pressure of 140, 150, when you move, when you stand, when you get up of bed, it may drop to 120. So we try to give it a little room to keep it around 140s, 150s, so it doesn't drop and patients don't fall, they don't have fractures or anything like that. So hypertension is the same. You have to be individualized. You have to be according with what the patient has and what other comorbidities we may find. The geriatric syndromes. So we have all the geriatric syndromes that we see in older patients, and we have to take in consideration these things. The patients with diabetes will have more falls. They have more weakness, muscle wasting. They will tend to have less mobility. About nutrition, their diet, how they eat, and sometimes depression. Depression is very common on seniors, and we have to make sure, like, sometimes I have seen patients in the clinic, they're doing pretty good, they're taking the medications, the A1C is well controlled, the sugar is okay. Something happens at home that they get depressed, and sometimes we don't peak it at the clinic, but then we can see the numbers that are getting worse. So we need to find out what is wrong, so in that way we can prevent it, we can treat it. So depression is one of them. Like sometimes it happens, and then we see that diabetes get out of control because the mood change. They get more sad, and they don't want to eat. They don't want to take their medicines. So that's a really important one. Dementia, it's another geriatric syndrome that we have to be careful with when we manage dementia and diabetes, because depending on the cognitive function, so how much people can remember the medicine. We have to do a good history. We have to take in consideration what the family says about like how they are taking the medications, if they are taking it, if they are forgetting. So with dementia, and then also what medications we need to use. For example, if a patient can drink and eat, maybe a pill would be a good option. But if they need help, or the family members in there, maybe an insulin would be a good option, 1 shot a day. So we have to be very careful with how advanced is the dementia and what we can do to help without getting more complications, without dropping the sugar or letting the sugar be too low. Urinary incontinence is another issue, like sometimes patients with hypoglycemia tend to increase the urination and become incontinent. So we have to make sure we control those the sugars as well. Don't let it be too high. Diabetes and the frail. When we have frail patients, a little weak with a lot of comorbidities, we have to make sure what are the goals for our blood pressure, what are the goals for our glucose, because we cannot be very aggressive because our A1C is like a little high. We have to keep patient comfortable. We have to let them enjoy that. We have to make sure it doesn't get a lot of hospitalization because we don't control their sugars. We have to make sure that the balance the quality of life, and we have to check other risks, the ulcers, malnutrition, dehydration. Make sure they drink a lot of plenty of fluid when they are diabetic as well. Some of the treatments, I already talked a little bit about this, but we have to balance. We have to make sure our patients take the medications, make sure somebody's at home, make sure if they live alone or they live with somebody, if they take their medication, somebody else give it to them. So we have to see our patients and make sure what's going on to treat the diabetes accordingly. The target for blood pressure, I already talked about it. Like we try to let it be a little higher. If they have a lot of complications, maybe 140s. If they have less complications, maybe 150s. Actually, the low blood pressure, low systolic blood pressure, increased risk of cardiovascular events. That was done in a study in the last couple of years, and then so that's another reason we try to let the blood pressure be a little bit higher than the normal. Anybody with diabetes at 50 would try to do it differently. There's no evidence of support type control or any of the blood pressure or diabetes. We try to prevent complications only. There's modest treatment reduce cardiovascular risk in older patients. So we try also that no avoid treatment based on age. So sometimes we see doctors like, well, they have a lot of complications. Well, let's just let it be. Let's just don't do anything. But we have to make sure also they don't get too dehydrated. They don't get too hyperglycemic that they get confused. They get delirious. There's a relative risk reduction for secondary prevention of cardiovascular events in older patients with diabetes, as same as for younger age. Given higher likelihood of cardiovascular events, this stress leads to potential for greater absolute risk reduction of cardiovascular events. This is the target of our A1C. It's between 7 and 8 for a patient that has less comorbidities, they don't have heart failure, they don't have hypertension, there's no fractures, so we try to keep it like around 7 to 8. And if they have more comorbidities, they are in a nursing home, they're in a community, so that we can let it be a little bit higher, between 8 to 8.9. There are a lot of studies done, like there's more risk for hypoglycemia than hyperglycemia. Same thing that I've talked to you about the functional status. Make sure that they can walk, they can see, they can think right, they don't have any cognitive decline, they don't have neuropathy, they don't have kidney failure. Insulin is sometimes it's really hard. We have to pick the right insulin for them. There are new ones that you have to do a shot once a day. There's even a new one that you have to do a shot once a week that is not very often used, but those are options that we can use in the moment that we have patients that have a lot of cognitive decline or they have dementia, and if somebody else helps them, we can teach them how to do it. So those are options that we have right now instead of pills. Sometimes people don't like shots, and I agree with that. So sometimes then we can try to manage according with medications. We can still use metformin. Metformin is a good medication to use. Glipizide, even like if it's sulfonylurea, that increased risk of hypoglycemia, it's a good medication because it's short acting and it doesn't affect the kidney. Like I said, vision, make sure like the vision is okay. Glaucoma, if they have glaucoma, cataract, it can be corrected with laser or with surgery. So, and then we can continue the treatment without any problems or less complications. Arthritis of the hands, that's another very good thing that we have to make sure it's okay, because sometimes when we talk to patients, we tell them like, well, just use insulin. But when they have a lot of arthritis on their hands, for them it's really hard to get the insulin the right amount and inject themselves. So when we see, or when we have family, we have to make sure they can do that, or somebody else can help them. The cognitive status, make sure like if they have Alzheimer's or any other type of dementias, what is the correct management, what we can do to help them. Sometimes if the patient wants to be independent, we have home health companies. We have people that can go to the police. We have ways to monitor glucose with home health companies too. And they also can do insulin injections if some of them can do. So that's another way to we can make sure that diabetes is well controlled with medications or with all the measures that we do. And same thing, we try not to avoid the treatment. If any complication, we try to treat what we need to treat and try not to be too aggressive when we don't need to. Metformin, like I say, is one of the medications that we can use. Now, metformin, before it used to be like, when they have kidney problems, we cannot use it for the increased risk of lactic acidosis. It's still on the beer list. It's a medication that should be very careful on older patients, older adults. But lately, I studied, and it was done last year, we can still use it even like if the creatinine doesn't hit 2.0. So, but I actually like to make sure the GFR is good to use it. So that's it's still a good medication that I still use it. Sulfonylureas, other medication, Actos. When somebody's in Actos, we have to make sure they don't have heart failure because it increases the fluid on their bodies, and then they put them on heart failure, acute heart failure, and they end in the hospital. So that's another one that we have to be careful. And like I said, don't avoid insulin if they need, if we need to use it. So all our patients have higher risk of bad outcomes, as I told before, like about for hyperglycemia, hypoglycemia. The evidence suggests modest treatment goals is better with best outcomes than tight control. That's my presentation. And any questions?
You were saying that there's a percentage of some of the people with diabetes that could have dementia. Is there any statistics saying what kind of percentage you're looking at on the increase of dementia?
When they have dementia and diabetes, it's very low because we don't diagnose dementia. I mean, diabetes very often at the age of 65, so it tends to lower. So the patients that were diabetes before, they get dementia. So it kind of becomes, I think it's not as high as the statistics are saying. Like right now, it's 30% people have dementia, and then that's at the age of 80. So, and that's total population. So it could be like between 20–50%. But we have to we have to also take in consideration that diabetes is increasing. So it may be in the future, it may be more patients with dementia with diabetes. So, oh yeah, yeah. So for their feet, if they've been diabetic for a long time, they tend to develop this complication neuropathy. So they lose sensation of their feet. So they may not tell you, but sometimes they don't feel anything, or they feel like too numb, too much tingling, and what we have to be careful is they don't have any ulcers, or what is around the house, like for example rugs, tables, or cables. Sometimes a small bump can become an ulcer, so that's why you have to be careful. And then also you talk to your doctor and then make sure how good is the diabetes? I mean, is it too tight control? Is it too high? So if it's too high, you may have more risk of complication on the neuropathy. But if it's too tight control, it may be better for the patient. So that's why you have to be careful on the neuropathy. Like make sure that their feet are okay. Check them often. Use comfortable shoes, and just check their feet out to make sure that everything is fine. Any other questions?
What about salt? I'm always hearing about salt. I mean, everybody puts lots of salt in their food and that's bad, so I'm always hearing that.
Yeah, well, salt, if we have a patient with heart failure, we have to be careful with salt, that's for sure. But we have to also check the life expectancy. See, for example, my loved one, it's like have a lot of complications. Talk to the doctor, see, well, what do you think? What is the prognosis? So for me, if they have a lot of complications, I want to give them a good quality of life. Sometimes I tend to be okay with salt. And there's another thing, like when they tend to have a lot of falls because of the blood pressure being too low, sometimes there are doctors, so there are some providers that can recommend a little bit of salt. So yeah, but it's not very often. But we try to avoid it as much as possible. It still is it's bad for our fluid. It makes us sweat a little bit. So that's why we think about salt. Any questions?
You mentioned that the target A1C for an older diabetic would be 70 to 80. What would you consider an older for diabetic around that age?
Well, more than 65, and then when they hit 80, sometimes we have to make sure like what other comorbidities they have. So we try to target according to what they have, what diseases they have. So that was lately, like last year, the American Geriatric Association and the Diabetes Association, they got together and they agreed, like, it doesn't need to be too tight for seniors, for 65, 70 years old patients.
Everybody always talks about type 2 diabetes, and of course it's 25 times as common as type 1. And so type 1s kind of get ignored, but if you have a type 1 patient with severe hypoglycemia unawareness who has routine severe hypoglycemia and maybe loses consciousness, over the long term, what does that do to the brain?
Well, the hypoglycemia, well, there's a slight association, not with hypoglycemia, but with hyperglycemia with cognitive decline. The hypoglycemia, well, what it does is just like make you more confused. And then also with type 1 diabetics, we don't see it very often when they reach 65. Not because it doesn't present at that age. So it's really hard to see a type 1 65. And then also like, but people's living longer, so that's why we're seeing more often a little bit than what it was. But the hypoglycemia with what it does to the brain, it's not a study for the cognitive decline, but it may get you more confused a little bit, but it doesn't affect you on the cognitive decline too much in the long run. But the hypoglycemia, yes, now it's linked to cognitive decline as well. So there are a lot of studies done, like you have to be tight control hypertension, tight control diabetes, but we have to make sure like we cannot say that to everybody. We need to see patient by patient, make sure like who can do tight control, who can do a little laboratory. I mean, a little, you know, giving a little bit of room on the treatment. Don't be too tight. Any other questions?
So Dr. Pardo could give you a couple minutes after we're done here, if you would mind stepping out and maybe speaking with him privately, and you guys could arrange an opportunity to meet up again. So hang tight on that, okay? Dr. Pardo, thank you very much for being here today. We appreciate it. You know, all of our speakers have donated their time to us today, and you know, it's through their support in helping us gain knowledge and learn what's going on here in San Antonio in particular. So, did it warm up in here? Yes. Okay, good, because we tried to work on that. So we are in a great position for you to get up and stand up, get some blood flow to the feet, have some coffee, have some snacks, but most importantly, go visit your vendors. We have a 30-minute break, and we're going to be getting together at 10:30. Actually, it's now like a 25-minute break. Go visit your vendors. Go to the Memory Cafe. Remember, we have vendors over here around the corner as well for you to review. That's our community resource room. Thank you.
Like a dog without a bone and nectar out alone, riders on the storm. There's a killer on the road. His brain is strumming like a toll. Take it all.